Before I introduce our speaker, I want to do a little bit of housekeeping. This CME activity is sponsored by the Hawaii Consortium for CME, which is a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, University of Hawaii. As a reminder, evaluations are required for CMEs. You can find evaluations by following the link in the chat or at any time in our website and email advertisement. Your comments are very important to the planning committee and are used for future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy, and Dr. Lee has disclosed that he has no relationship with commercial supporters that could be perceived as a conflict of interest for this presentation. It's my great pleasure to introduce our speaker, Dr. Thomas Lee. Dr. First Lieutenant Lee has been in the United States Army Reserve since December of 2018. He got his bachelor's degree from the University of Notre Dame and his master's and PhD degrees in public health from the University of Hawaii, where he is currently an assistant professor of epidemiology. From April through July of 2020, he served as the lead forecaster and modeler for COVID-19 for the Hawaii Emergency Management Agency, or HAEMA. Lucky for us, he's continuing his work in the Army Reserves as a medical planner, where he also holds many leadership positions. And I just checked with him, and he's still spending a lot of his time on the state's COVID response, for which we're all very grateful, Thomas. His awards and decorations include the Army Commendation Medal, National Defense Service Medal, and the Army Service Ribbon. Please join me in welcoming Dr. Thomas Lee for this very important COVID-19 update, and he'll talk a little bit about the vaccine as well. Thank you, Dr. Lee.
Thank you, Dr. Masaki, for having me, and aloha, everybody. Thanks for taking time out of your busy schedule to participate. Hopefully, you'll take a few things away from this. Just to give you a little more perspective, right now, a lot of the medical planning that I'm doing is at a big Army level in terms of the entire Pacific region. So working with logistics and data tracking for COVID vaccinations from the West Coast all the way to Korea and Japan, and well within the Indo-Pacific region. So just to provide some perspective. So as you can see, the focus of this talk today is really updating on COVID vaccine and also some of the variants that you've been seeing pop up the past 2 to 3 months in both peer-reviewed journals and also in the media. So just a quick overview on how this, what I'm going to hit this hour. Really just go over the current approved vaccines and then some of the impacts by the current vaccines and how that really impacts the supply chain, logistics, and distribution, and take a step back and kind of do a slight dissection of the initial rollout nationally and how that impacted Hawaii, and then move to current major circulating variants and the vaccine efficacy against those variants, and then what the future is going to look like to the best of our ability. I know we have clinicians, we have other medical professionals, so I apologize if I'm repeating some of the information that you may be aware of, but it's always good to level the bubble and level the playing field in terms of vaccines. The latter part of the presentation will focus on some of the issues we've been seeing on messaging within the Army, as well as in the public. So I'm trying to get a holistic public health view as well. So the Pfizer vaccine, one of the first 2 approved mRNA vaccine, it's the only one approved for 16 years and older, so for minors as well. As the FDA continued to update guidance, we are now able to get 6 approved doses from the vial, which originally was at 5. If you look at the storage, it's probably the one vaccine that has the most limiting factors when it comes to cold chain storage. So -90 Celsius and -60, and then you have some additional caveats to that as well. So once you take it from the cold chain, the super cold freezer, and you thaw and then and you store it in the regular refrigerator, you can store it for up to 5 days. And then the undiluted vial may be stored at room temp for more than 2 hours. So if you just look at this, and I'll go over this a little more in detail, comparing that to Moderna and Johnson & Johnson, but just thinking about keeping track of the times and making sure we don't waste any of the vaccine doses, it can get very complex, especially when you're talking multiple facilities across a large area. And then, of course, the timing of the doses, which also plays a role in data tracking and making sure we don't waste a vaccine and getting people fully vaccinated. Between dose 1 and dose 2, you have 21 days, though FDA and CDC have updated that to give more of a wider room for margin of 42 days by the CDC. And also, it's important to note that current guidance is to give both doses of the same vaccine, no mixing and matching between Pfizer and Moderna or vice versa. I'll tie this in. The reason why I'm focusing on this for a slide is I'll tie this into some of the reasons why people do not get vaccinated. So these are the largest, the most common adverse reactions, as you know, the clinicians on board are I'm sure aware. A majority of these common side effects will resolve within 24 to 72 hours of the administration of the vaccine. And the CDC published in their MMWR recently that you know, there were very few anaphylactic reactions per 1 million doses or administration of doses for both the Pfizer and Moderna. And majority of those anaphylactic reactions occur within the first 15 minutes. And a majority of those also had a history of adverse reactions. So in terms of safety, it's very safe in terms of short-term impacts. Moderna, pretty similar, you know, mRNA vaccine as well. 18 years and older is the approved audience. Looking at the storage, not quite as cold chain in terms of the storage, so it's a little easier, provides a slightly more flexibility. So in terms of how it's being utilized within the military, we prioritize Moderna doses for those who are in regions that take longer to get to. So, you know, thinking about how that applies to us locally and some of the differences in the supply chain and the storage and how that can be utilized differently to get to different areas. And also it's a 2-dose regimen. This one 28 days apart, and the same caveats apply in terms of if you can't make the 28 days, you have up to 42 days. And the storage is a little different, multi-dose vials, 10 doses each. Adverse reactions, a little higher percentage for pain and injection site, and then also percentages for fatigue, headache, myalgia, and joint pain are also a little higher for the Moderna vaccine. One other side effect I forgot to mention for the Pfizer is that we have had some documented cases of inflammation of the lymph node under the armpit on the side with which you got the vaccine, and that actually happened to me. I was wondering why my chest felt tight, and then a couple of weeks later, I was reading, I think it was a New England Journal of Medicine article saying that females who were going to get mammograms and who also got the vaccine recently were told to come back at a later date because of this side effect. So once again, we're seeing this impact some of our other public health screening efforts. Finally, there's been a lot made of the approval, the EUA for the Johnson & Johnson vaccine that came out, man, I think it's 2 weeks ago. It's crazy how quickly new information gets pumped out. So I believe it was 2 weeks ago. Please don't hold me to that. But the biggest benefit to the Johnson & Johnson vaccine is that it is a single dose, at least as how it's currently been approved by the FDA. That being said, they are currently holding trials to look at potential utilization of a 2-dose regimen. However, we're not expecting any results in the near future in terms of their phase 3 trial results. If you look at the storage and the requirements for that storage, I have a slide that compares the three, but it's a lot. It does not require close to the type of cold chain storage that both the Moderna and the Pfizer vaccine requires. Okay. So before I kind of do an overview of what happened historically, this is kind of to just plant the seed and to think about all of these major overarching issues as I go through the rest of the presentation. Some of the things that the planners have to think about besides supply and logistics is also creating communication and trust between public health professionals, clinicians, and people getting the vaccine. Figuring out the roles at a federal, state, and local, and territorial and tribal level, coverage costs, and then obviously within Hawaii, where we're all aware as we practice both medicine and public health, that there are racial and ethnic disparities, and understanding how to mitigate them and to work with those disparities to make sure there's equal access. And I'll touch upon that as well. And then funding as well for this effort, vaccine effort, and how it relates to the overall COVID-19 relief. So this I created this slide just to really highlight the stark differences in the storage temperature between the three approved vaccines. So Pfizer, Moderna, Johnson and Johnson. You can see the limiting factor for the Pfizer vaccine is the cold chains, the cold storage, as well as the Moderna to a certain extent. And then you can see the flexibility that the Johnson & Johnson vaccine provides in terms of the storage and potential utilization at certain harder to reach facilities, and potentially some of our kupuna who can't leave their homes, and maybe a roving vaccine van that gets to these areas and doesn't have to worry about that 2-hour time limit for the Pfizer vaccine. Tying in the larger supply chain for the two, I apologize, I don't have one for Pfizer. For Johnson & Johnson. I'm just trying to work smarter and take what resources have been approved by the FDA. So this kind of compares and contrasts both the Pfizer, Moderna, as it pertains to where it's produced and where it needs to get through to get to the vaccination center. So Moderna has one additional node that it must hit, which is the distribution center, versus the Pfizer can directly ship to the hospital. So once again, thinking about those considerations as a logistical concern, and then the differences between Pfizer and Moderna. Let me see. Kamal, for questions and answers, will people just post them in the chat? I want to make sure that, if there's any burning questions, I address them as we go through and not just wait to the end.
Usually we do it at the end, but
okay.
I can let people know that if they do have questions, they can tell me. So I'll be moderating the questions, so you don't have to worry about the chat box, Thomas.
Perfect.
But
thank you so much.
Audience, if there are any questions, please put them in the chat box, and then when there's a point where you pause, Thomas, I might ask them.
Sure.
Okay, thank you.
Perfect. No, thank you for that. Okay, so moving on to the initial vaccine rollout. Unfortunately, looking back now, there are many similarities between how the COVID-19 testing kind of rollout occurred compared to the current COVID-19, or the initial COVID-19 vaccine distribution rollout. There was limited, if any, federal guidance or a dedicated plan that was pushed for both the COVID-19 testing strategy and distribution and logistics supply chain, and similarly for translating that to the COVID-19 vaccine, and a very generic or general guidance from the federal level to the states in terms of how to conduct vaccine rollout, and also how to conduct messaging, et cetera, and to target specific populations. Additionally, some of the reasons that the states were left at planning at a higher level and not being able to get to the detail level ahead of time was that there was unclear data on just how many doses from the Moderna and the Pfizer brands would be allocated and sent to the individual states, and also when. And the secondary and the tertiary impacts are pretty apparent. If there's no timeline, then it's really hard for the states to coordinate with, the facilities that can accommodate the cold chain storage that's required for Pfizer, Moderna. So locally, that'll be Queens, HPH, our larger medical treatment facilities, and then military, that'll be Tripler. Without some of those details, it's harder for those respective medical facilities to do their own planning. And so you're kind of, unfortunately, again, with this whole COVID response, we're kind of building the plane as we fly it. So that leaves a lot of speculation and a lot of room for error when we actually get the vaccines and have to deploy it. So the initial vaccine plan or group was called Operation Warp Speed, and it's a collaboration between the HHS, so Department of Health and Human Services, and the Department of Defense. And a big thing to highlight is that historically, those are not the entities that are in charge of vaccine rollouts for previous outbreaks. Typically, it's led by CDC, and therefore, with a change to who's leading it, who's running it, you can already see that they're going to duplicate efforts. They're going to basically recreate the wheel, and therefore that further pushes back the timeline, creates lines of communication that may be crossed, and creating silos, and then having to break down silos, and really wasting precious time. So that's important to note. Fall of 2020, each state was required by the CDC to submit plans. If you just Google Hawaii specific or Hawaii COVID-19 distribution plan, you can see that it's very high level, just hitting some major benchmarks that were set by the CDC, but not a lot of specifics in terms of where they might identify specific vaccination pods, the size of the pods, what's the throughput, where they might pull the staffing, all these things that should have been already identified as prior to getting the vaccine, and then it's just a matter of execution. And therefore, there's a lot of issues that are connected to the supply, the cold storage, that kind of were propped up, and that were identified only when execution occurred. So, at a higher level, miscommunication, lack of a plan had a strong trickle-down effect in terms of how we as a state were limited in the vaccine rollout. And you can see that, Civil Beat, as well as Hawaii News Now and all of our other local news sources did many pieces on why our initial COVID vaccine rollout was so slow, was so limited, when there was so much time, when we had a lot of lead time to plan for it. And so you can see from the snippet that I posted, the state was actually doing quite well based on the doses that they were receiving. There was not a lot of lag in terms of doses received versus doses, shots in arms. It's just a matter of knowing when they were getting it, and how much was being allocated for the following week, and then communicating and working with Queens, HPH to get that messaging out to the community for the Pier 2 mass vaccination sites, and getting everybody signed up. So because there's a lag at a much higher level, then that resulted in an even bigger lag when it came to coordinating within local and state partners to get the individuals signed up, especially within our respective phases. So just a quick highlight of Hawaii's phased response for COVID. So we're all on the same page. So starting off with phase 1 alpha, healthcare workers, healthcare personnel, long-term care facility residents are our highest risk population. And then moving to phase 1 Bravo, first responders, frontline essential workers, and 75 years and older population. And then I think we're slowly moving to the point where we'll transition to 1 Charlie, the 65 to 74, high risk medical conditions, those with diabetes, hypertension, overweight, obese, and then essential workers previously not included in 1 Alpha, 1 Bravo. And then the goal I know there's been varying reports of maybe May by Lieutenant Governor and also May by President Biden that every single adult in America who wants a vaccine will have one by May. So um, we have these higher level messaging, and sometimes it's hard to follow through because we have unexpected circumstances such as the snowstorm in Texas that definitely disrupted the supply chain and getting vaccines to the states in a timely manner. So, uh, I get trying to uh, provide a positive messaging to get people motivated to get vaccines, but having leaving some wiggle room and so that expectations are being managed. So wanting to hit some of the logistical and more of the higher level planning piece that may often be missed when it comes to the vaccine rollout. So this is how I see it, the way I categorize it. You have an appointment-based strategy and a mass vaccination strategy. And then that third bullet point is where I see us eventually moving to. Just not sure when that's going to happen, that a normalized operation tempo. And I'll explain what that means in a further slide. So your appointment-based strategy, that's kind of what we utilize in the beginning and what we still have to a certain extent, identifying specific people based on where they work and what their profession is, and scheduling them at specific times based on when the hospitals and the treatment facilities know they're going to get doses. And the strengths of that, there's a lot more control over that vaccine doses, much less waste because you're not going to overschedule. At least the chance of you overscheduling and wasting is not as bad. You would rather overschedule than to underschedule and have a bunch of doses thought out and not having to be able to have shots in arms. This particular strategy is more feasible when supply is limited because the number of people, the pool that you have to work with is smaller, so you're not the lift required at a data management perspective, at a data coordination perspective, is a lot easier. And then it's also for Moderna and Pfizer, it was a lot easier to keep track of second doses, remembering that back in January and late December, the only guidance was it had to be 21 days or 28 days for Moderna. There was no wiggle room originally put out by the CDC. So being really strict with that timeline, and that resulted in having to keep track of the interval between dose one and dose two, and it's a lot easier with an appointment-based strategy with a smaller population. Limitations, this will be both for any type of strategy, but just keeping track of a person getting Pfizer both times versus Moderna now versus Johnson and Johnson. And then, initially, from that prior slide, insurance systems, who's going to pay for it now versus in the future if there's boosters. And then also one of the biggest is less throughput of shots in arms because you're controlling it at an individual level. It takes away the time to get more people vaccinated in terms of shots in arms. We've also utilized a mass vaccination strategy both at a federal level and at a state level. Peer two, I think peer one or peer two had, and then the convention center as well. The biggest strength is it allows us to get a lot more shots in arms than the appointment-based strategy. It's theoretically should be easier to sign up because you're going to a single site. And to sign up, you're not going to Queens, which is HPH, or CVS, and it's just one-stop shop. And also we're decreasing potential transmission around our medical facilities, and that's a big plus. Even though in Hawaii we've had a much lower prevalence and circulation of disease at a national level, that's really kept transmission lower around the hospital setting and healthcare facility setting. Once again, limitations, potentially loss of control when it comes to knowing who's coming. I've heard stories of people who are healthy adults who have, because of the chaos that just results of the mass vaccine kind of strategy, have gotten it. And while that's not bad, theoretically, not wasting a shot, we're not getting the shots in arms of the people who are most vulnerable. So that is a limitation of this type of strategy. And you potentially have a scenario where you have increased wasted shots, where you account for 2,000 shots in arms, and not everybody shows up because it's just, even though you sign up, it's more of a free for all, and then you're having to hunt down random people so that you don't waste doses on the magnitude of tens and 20s versus single digits. The other limitation is that it does require a lot more manpower. Thankfully, with current COVID funding, that has been an issue with the National Guard supporting at a state level. That hasn't been an issue. But as funding slowly gets used up, that may become a potential limitation as well. So current vaccination sites, hospitals, healthcare facilities. CVS now is offering it for Kapuna. And then, this is a picture of the convention center of mass vaccination sites. And obviously storage considerations between, for Moderna, Pfizer, and now then Johnson & Johnson will have an impact of where the vaccines are being deployed, whether it's a hospital, CVS, those drugstores, or a mass vaccination site. Less likely that Pfizer will be given at CVS, more likely Moderna or Johnson & Johnson, simply due to the limitations of the storage. Let me move back to this normalized operational tempo. I'm going to talk briefly about it now, but kind of come back to it towards the end. So what I mean by normalized operational tempo is eventually the COVID vaccine, and whether or not it becomes a booster, will become part of, at least this is my, what I suspect to be what will happen is it's going to become part of our daily or yearly vaccine regimen, where, COVID will probably become endemic. And then at some point we either get a booster every year, every 2 years, depending on how quickly the virus mutates. And then it'll be part of our yearly checkups. And that's what I mean by a normalized op tempo, where we're not having to utilize max vaccination strategies or even appointment-based strategies. We'll get to a point where once the initial push and rollout is complete, whenever you see your provider, your PCP, that will, and they're tracking when you last got it, then they'll advise when the next time is recommended to get your booster based on what the science and epidemiology is saying. So just wanted to put that out there. That's probably what we're going to transition to for a longer term response. So moving on to efficacy against current variants. I am definitely not a virologist. I like to talk to them. This is not my area of expertise, but I think there is a lot of value added in synthesizing it and taking the hard sciences and then applying it to a population level, and understanding that what we're seeing in the lab and in small sample sizes may or may not be applicable to generalizable findings and maybe policies at a population level. So that's just a caveat before we go on to the next section. So the major strains, and I think just today, Hawaii News Now reported that there was the first report of the South African strain in Hawaii, found in a person with no travel history, which now brings it to within Hawaii, we have now identified at least a single case of all three international strains, the B117, B1351, and now the P1 variants within Hawaii. So that's at a state level. At an international level, you have your B117 or UK strain, which is the first of the major variants that occurred last year. Initial findings show that it is associated with increased transmission. However, what we have so far doesn't suggest that it impacts negatively or there's any increase in morbidity and mortality. But we're still waiting on updated information. And also from lab studies, from serology studies, taking blood samples from previously vaccinated individuals with both Pfizer and Moderna compared to the new strain, we still see a pretty strong immune response with the blood of those who are currently, who had the original version of the vaccines, Moderna and Pfizer, compared to the UK strain. So once again, from a serologic and immunological standpoint, we're still protected to a strong degree. It may not be as high percentage, but once again, we don't need a 95% efficacy across all the board, because the immune response is not, it is pretty varied across the strains. And then the B1351, the South African strain, currently no evidence to suggest that this particular variant has any impact on disease severity. However, the reason why there's been a lot of focus on this particular vaccine is that on the spike protein, there's a specific mutation that has been shown to reduce the uptake of the current vaccines, mRNA vaccines, against this particular strain. Once again, that doesn't mean that the vaccines aren't going to work or aren't going to be effective. It's just showing, the lab studies have shown that it reduces efficacy, but from an overall immunologic perspective and epi perspective, that doesn't mean that the vaccines do not work, and we should still be pushing on the messaging that the vaccines will still be effective to a relevant degree against the UK and the South African strains. Finally, the most recent of the international variants is this P1 Brazilian strain. Because it's the most recent, we're still waiting for more of the data to be published in our peer-reviewed journals. The early evidence does suggest that it potentially has increased transmissibility due to its antigenic profile, and potentially might decrease our antibody response. But once again, until we have more and more information, which definitely updates on a day-to-day basis, and I may have missed stuff throughout the past week or two, we're still waiting on more guidance for this particular variant. And then most recently, in the past 2 weeks, we have two national, local in terms of our country strains, the B1427 and B1429, which is the California strain, and then the B1526, which is the New York strain. And the reasons why those are important: one, they are organic to the United States, and then for California, it currently accounts for over 50% of cases in over 4 different counties. Still studying potential infectivity. And then the New York strain, some of the preprints, it's been associated with a 12% increase in cases from late December to mid-February. And then there's been identified a unique spike mutation. That's important because if you take what you see on this particular slide and just take a couple steps back and at a state and a national perspective, and how we're trying to open up tourism, and potentially, loosen up restrictions in terms of quarantine and maybe testing requirements. California is a state that makes up a large proportion of both our tourists and residents who travel to and return from California, and then New York to some extent as well. So, until we get until we increase the proportion of our population that's vaccinated, and get a better handle of the circulating strains, and increase our genetic surveillance, it will continue to be an issue of concern, at least for Hawaii, and continue to monitor. This particular slide and the impact to this topic of vaccine efficacy messaging is huge, not just within the federal enterprise, but at a state, local, and a national, international level. So this first slide is what's being broadcasted. What you'll see if you Google and on a CNN or Hawaii News Now, kind of a banner, where Pfizer's 95% effective, Moderna is 94% effective, and then you see Johnson & Johnson, right, 72% effective in the US, but what's really being messaged for Johnson & Johnson is this 66% overall efficacy, versus what I think should be broadcasted and what we're pushing at a public health messaging level is, efficacy against severe COVID, 95% for Pfizer, 94% for Moderna, and 86% for Johnson & Johnson. And you can see how if we message this, the uptake of vaccines or the willingness for the Johnson & Johnson will go up, and that's really going to have a positive impact both locally and a national level. What I've been hearing and seeing is that people want to choose. They're basically declining Johnson & Johnson if they were offered it, because they feel like it's less effective. They want the best one. They want Pfizer. They want Moderna. because they think that it's better than Johnson & Johnson. But if you truly look at the studies and the efficacy, they're pretty similar, and trying to educate the public that, for the most part, the goal is to keep people from dying, to keep people out of the ICUs, out of the hospital. And all three of these vaccines do a tremendous job of that. And basically, if you're offered a vaccine, you should get one. That's the important message. There have been 0 cases of hospitalization of death in the clinical trials for all of the above vaccines. Oops, I apologize. So, at a individual level, at a local level, at a national level, that needs to be continued to message, especially as we roll out the Johnson & Johnson vaccine, and to tell people that, just get whatever vaccine you can get. Obviously, with the logistical and the storage issues, depending on if you're in a specific subpopulation, then you may be getting one over the other, but that's because of supply chain and logistical issues, not in terms of the efficacy concerns. Some other things that you should be aware of when it comes to comparing efficacies is that is the timing of the trials and the location of the trials of Moderna and Pfizer versus Johnson & Johnson. So timing, both Pfizer and Moderna completed enrollment of their phase 3 in October, and the results were published in November, versus Johnson & Johnson completed enrollment of their phase 3 trials in December, and results were published in January. And if you think back to the previous slide with all the variants and think of the timeline, when the Pfizer and Moderna phase 3 trials were being conducted, they really were not having to worry about the variants because they weren't at a point where it really severely impacted efficacy findings. Versus Johnson & Johnson, the timing, just a month later, they were having to deal with the UK variant and some of the other variants because not only the timing, but also of the locations where the clinical trials were being conducted. For Pfizer and Moderna, the majority of the trials were US-based participants, versus Johnson & Johnson conducted over 8 different countries, the United States, and then Latin America and South Africa, where once again, you have these variants circulating, which result in a decreased efficacy in terms of what you just see statistically, but then taking a step back and comparing and understanding that these are not apple-to-apple comparisons that should and can be made. So this is my last slide. I want to make sure I leave plenty of time for Q&A. So some future efforts, I purposely didn't draw any arrows because they're all interconnected, and they're going to change as the response continues to evolve. So we have these new variants, which I touched upon. I also mentioned briefly that we're going to move from a pandemic response to an endemic response, and not quite sure how that's going to look like, but I foresee that happening. And then the booster shots, both Pfizer, Moderna, and Johnson & Johnson already starting to work on booster shots to their vaccines to address the current major circulating variants. And then we're still waiting on data from trials to be able to vaccinate children. And from what I've heard from Dr. Fauci, it doesn't seem like it's going to get we're going to get there anytime soon. Maybe by the fall, we'll have some results, and then the FDA can provide guidance on the age ranges for childhood vaccinations for COVID-19. And last but definitely not least, vaccine equality. We have the COVAX effort trying to get vaccines to third world countries, to countries that just don't have the ability to buy up the initial stockpiles of vaccines that United States, Japan, England, Canada, France, Germany, all of these first world countries kind of snapped up all of them, and understandably so. But if you look from a global health perspective, we're not going to get this response. We're not going to be able to control and really reduce the overall level of transmission until we can significantly reduce transmission at multiple country level because of our globalization and international travel. If it doesn't make sense to have 100% vaccinated effort in the United States when then we travel to other countries that haven't gotten as far, and then there's a variant that the vaccine doesn't work against. We bring that back to the United States, and then we have another outbreak. So having multiple lines of effort, both within our country and internationally, to make sure everybody's having equal access to the best extent possible to at a global level to really reduce future transmission of COVID, and then also locally making sure we continue to identify and work with our marginalized communities to ensure equal access of vaccination efforts, especially with our disenfranchised populations. And then finally, at the bottom, with the new administration, one of the first things that they dropped was their national strategy for the COVID response and future pandemic preparedness. And understanding that there was no formal plan that the previous administration utilized, and that probably played a strong role in how things played out, and now wanting to make sure that we don't make the same mistakes moving forward. There is now once again a national strategy for this current response and future pandemic preparedness. So with that, I want to first thank Dr. Masaki and her department for having me speak, and then last thing is I am the co-chair of HIPAM. And HIPAM was stood up with Dr. Victoria Fan, who's an associate professor, the interim director for the Center of Aging, as a way to figure out modeling and forecasting within our state. There was no formal entity at the start of the outbreak, and HIPAM is a collaboration of a state, a local, public-private partnerships and leaders within the health space, both clinicians and outside clinicians, to really address first and foremost the modeling and forecasting, and now just to look at the overall response to include genetic sequencing, et cetera, and positioning Hawaii to be better in the future. So with that, I have about a little over 15 minutes. Dr. Masaki, it's all yours to moderate Q&A. Thank you.
Dr. Lee, thank you for that excellent presentation, a wonderful update for us to have. And again, thank you so much for what you've done for the state of Hawaii. These forecasts have helped, I know HAIMA and others in the state plan, and Hawaii, I think, has done much better than many other states on the mainland. And I think a lot of it is because of people like yourself who've helped towards that effort. So audience, if you could please put your questions into the chat box, and I will read them out loud for Dr. Lee to answer. Okay, so the first question is, somebody is looking for guidance on how to get my homebound community dwelling patients vaccinated. This is a geriatrician who's asking for that.
Thank you for that question, which is a very important one. Unfortunately, I don't have the answer, and not because I don't want to. It's the past couple months I've been not working at a state level response. I'm more at a higher level response within the Pacific region. But let me go back to one of my previous slides, going back to the phases. So oops, wrong slide. I'll send out a link. So there's a link for Kapuna 75 in order to get vaccinated. I'm not aware of any links where facilities can coordinate with the Department of Health, though I'm sure that is an effort that the state is working on. So, if that, whoever asked that question, Kamal, if you can link me up with that person, and I can do my best to liaise with the best contact within DOH and figure out how to address this issue, because it is important. I just don't have that answer off the top of my head.
Thomas, it's Dr. Mahe Lum, who's a geriatrician in the community, and definitely we can hook you up with Dr.
Thank
Lum.
you.
Are there any other questions? Okay, so the next question is there any evidence that the Johnson & Johnson vaccine will be less effective for older people with senescent immune systems? The news hinted at this, saying that they suggest the Johnson & Johnson for younger, healthy patients. Any thoughts about that, Thomas?
Yeah, that once again another great question. I have seen some reports where it's where the efficacy decreases as the as the age increases, and so the goal once again is to get vaccines, shots in arms for our elderly population where it's the most effective. So that would be the Pfizer. That being said, understanding that um, there will always be limitations, and if there's a kapuna that just doesn't have the capability or capacity to get to a place where they can get the Pfizer or the Moderna shot, or is at such a high risk that if they are able to, they might potentially put themselves at high risk of transmission, then we, the recommendation would probably be just get them better protection from the Johnson & Johnson vaccine, um, just so we feel better about the protection that is conferred by that vaccine. So once again, it's uh, as much as we all love and want very clear-cut guidance, um, there's so much of a gray area because of uh, these specific scenarios that are closely tied to storage, supply chain, that really it's up to um, it's the responsibility falls to providers and the Department of Health to really coordinate these efforts, and that ties into Dr. Lum's question, because this is probably going to be more skewed towards our elderly uh, populations and also our disenfranchised populations as well. So I'm sure Department of Health is already working on it. I just haven't seen any formalized plans for execution of that, but definitely the science does show that age increased age can result in a decreased efficacy for the Johnson & Johnson. But once again, there's so much more to consider than just the data itself.
I think, Thomas, this reflects what you told me before we started Grand Rounds, which is this whole COVID response has been like building an airplane while we're already in the process of flying it, and I think that's true. And everybody's kind of flying by the seat of their pants because there's a lot of unknowns in this COVID world. The next
Definitely.
question was, I think you addressed this, but if you could comment again, that the
Sure.
Johnson & Johnson has prevented 100% of hospitalizations and deaths. Are there any updates on those numbers, or is that still true?
I believe that's still true. I did my best to scrub the internet yesterday. And obviously that's for directly tied to getting the shot. There have been reports of people expiring shortly after getting the vaccine, but not directly due to the vaccine itself. Um, you know, but as a epidemiologist and someone who lives in statistics, there's always, you can never say with 100% certainty. It's just based on the information that has been reported and that we have. But to the best of my understanding, there haven't been any deaths directly related to the Johnson & Johnson vaccine itself.
I guess, does it prevent 100% of hospitalizations and deaths from COVID? I think that was what the
Yeah,
question
yeah,
was.
that's what's being reported, and what I did not mention, um, and based on the audience now, I think it's it will be well received that if you do a deeper dive and you look at how Johnson and Johnson versus Moderna versus Pfizer and then AstraZeneca specifically define both severe cases and also hospitalizations, you're going to see that it doesn't match up. And you could have 8 severe cases and only 1 hospitalization. And then the way that's defined across, between manufacturers is also not standardized. So once again, that adds another layer of complexity when you're trying to make overarching statements or comparing vaccines and efficacy. and then kind of nailing down some of the nitty gritty.
Got it. The next question is, would you happen to know how much medical support will be required at a drugstore versus mass vaccination sites like Blaisdell in the unlikely event of a severe reaction? The hospital where I received my vaccine had a code card, nurses, etc. Good question.
That is a very, very good question. Um, I, I can't speak to CVS and what their policies are. I do know that when I was doing planning to support potential DoD efforts to support state, the state vaccinations through FEMA, we had the majority of our personnel were people administering the vaccines. However, what was vital, and we had to have at least 2 people so we could rotate them through, was a clinician, whether it be a nurse or a PA or a provider, to provide that support in the event, for anaphylaxis in the event that that did occur. So I would hope so, because while the data has shown that it's very, very rare, there is possibilities for that, and we need to make sure that we account for that at all of the facilities that we're administrating it. It obviously is much easier at a hospital or at a medical facility, or even at a mass vaccination site, because it's going to be planned for. But as we roll it out across multiple CVS locations, that definitely should be a point of consideration to make sure that no lives are lost due to an anaphylactic reaction, and we can best transport them to a place where they can get the appropriate care.
Thomas, if I'm sure you know that CVS and Walgreens provided vaccinations at nursing homes all across the country and all across Hawaii. And actually, we found that they were not prepared, at least at some sites, they did not have any emergency supplies, and they expected the nursing homes to have those. So I'm hoping if they're doing it at their own sites, I hope that this will be set up correctly so that those emergency supplies and expertise is available.
Yeah, that's the goal. And once again, I apologize for not having the answer to this right away. But if I were to guess, right? So I get some vaccinations. I've received some at Walgreens, and so they hopefully, because Walgreens and CVS have a system where they administer vaccines at their sites, there's always a potential for anaphylaxis for other types of vaccines as well. So they should have already established policies and procedures to account for patients who receive vaccines at their sites to deal with anaphylaxis. So COVID shouldn't be any different, because the anaphylaxis will be the same regardless of what type of vaccine. So my hope is, to Kamal and for the rest of the group here, I hope that they have it. But once again, I just haven't had any visibility on the current rollout, at least locally.
Sounds good. The next question is, would appointment-based vaccinations be more efficient in the sense that documentation in the VAMS would be faster and next doses are ordered quicker? What are some logistical barriers that you know of in the pods that are currently happening?
That's a really good question. I would say that while I did lay out strengths and limitations, a lot of those can be significantly reduced, at least the limitations, if there is a strong plan in place and is communicated effectively. So what I mean by that is, if you have sufficient personnel whose sole job is to input the information into VAMs, and then that links into the medical systems, and then you have a backend system that automatically creates a second appointment for whoever went through the mass vaccination site, then that significantly mitigates that limiting factor that I listed for the vaccination site. So that ties into personnel and having the backend data systems set up. So if that's not the case, then you definitely would see a lot more cases where people do get their first dose, but because the data is being mismanaged or not being entered in a timely manner, where that messes up future allocations. I've heard anecdotally that depending on what site you're at, it's entered right as soon as the patient gets it, or it's being, because they just want to get as much throughput as possible, then they're going to be just vaccinating everybody and just waiting to enter everything in at a later time. So I've heard both of those happening, and just it depends on how delayed that response is, but the longer that delay response is, the greater the potential for missing, for papers going missing, and then data entry not occurring properly. So once again, there are best practices, but it really comes down to the execution, training, and communication across everybody who is running the mass vaccination site.
Thank you. Are there any more questions? While we're waiting for that, I just wanted to say, at least from my own experience with family members, the Pier 2 site was really, really well run. And I've heard very similar things about the Blaisdell site. So a lot of kudos to both HBH and Queens for setting that up.
Definitely.
Thank you, Dr. Lee. That was very interesting and very informative for all of us. Michaela has put a reminder in the chat box. Please complete your evaluations, which are required for CME credit. There's a link in the chat box that you can use, or you can use the link on the invitation email that was sent out. Dr. Lee, thank you so much. Please continue the wonderful work you're doing for the state of Hawaii. We really appreciate what you and your partners are doing, and you're welcome to come back and speak to us anytime.
Thank you so much, Kamal, and thank you everybody for your hour. I know that everybody's schedules are jam-packed, and we go to webinar to meeting, to Zoom to meeting. So appreciate your attendance and your participation, and hope to see you guys all in the future. Thank you.
Thank you. Okay, bye-bye.